It's my honor to introduce our third speaker, Professor Huang Yi-Chen. Professor Huang Yi-Chen now, she's currently in the Department of Nutrition, China Medical University, Taiwan. And Professor Huang, her major interest focus upon the nutrition epidemiology, public health nutrition, and nutrition for the older adult and the children. And Professor Huang and also done many study subjects and also published many papers. Her topic today is a modifiable healthy aging nutrition index, HANI, predicts the longevity in older Taiwanese. Ladies and gentlemen, please join me to welcome Professor Huang.
Thank you for Pastor Lin's introduction. I'm Yi-Chen Huang from China Medical University, and it is an honor to be here to share our research finding. Today, I will discuss a modifiable healthy aging nutrition index, maybe you can call HANI, predicts longevity in older Taiwanese. As many of you know, population aging is a critical concern for global health, not in Taiwan, also in Asia country in the global issue. While people are living longer, the quality of life often declines and the prevalence of disability is increased. However, a significant portion of medical expenditure is incurred in the last year of life. Therefore, how can we improve healthy and longevity in later life? A paper published in New England Journal of Medicine in 2007. This study indicates that the 30% genetics accounted for our health and well-being, and the 10% for healthy care, and 20% for social, economic, and environmental factors. For example, education, income, and the family and social support. But however, 40% of accounted by the individual behavior, such as diet and exercise. So that means individual behavior that affect our person's healthy and well-being. That's a very important issue. A study in Taiwan. This study to investigate adult mortality of disease and the injury attributed to select metabolic, lifestyle, environmental, and infectious risk factors. In this study, they look at the deaths attributed. However, the dietary risk is ranked 6, but you can look at, they have some factors related to diet. For example, high blood glucose, high blood pressure, overweight and obesity, and high cholesterol. That means diet-related factors are a leading cause of death. So nutritional factors are closely tied to food system, food availability, such as food accessibility, food sustainability, and the nutritional knowledge, skills, such as cooking skills, and all of which shape our dietary pattern and dietary quality. But however, older adults face unique nutrition challenges to limit their access to healthy diet. For example, reduced appetite, may someone call it a rush of aging, and difficulty in chewing, and cognitive decline. These factors leading them hard to have a healthy diet. Another issue is gender. The marked differences in healthy and survival between genders might be partially attributed to nutritional status. A study showed that women often engage in more healthy-seeking behavior and report more healthy issues and use healthy care service more than men. A study found that, for example, older men and women differ in their fruit and vegetable intake based on the type of social support they received. Men tend to need more tensional support, and women want more informational or emotional support. But let some few assess some tools assess nutritional risk factors by gender. Many studies explore modifiable nutritional or diet-related factors individually, such as Professor Aska and Professor Zhuang. But however, maybe there's many factors affect our nutrients and diet relative. Maybe we need a collective indexes. Even they have a collective indexes, but most developed in Europe, in Western country. But compare Europe or United States or other country, Taiwan have a different environmental, cultural, society, and diet behaviors. And even they have some integrated indices, but they have some limitation. For example, it's expensive, invasive, or limited availability. For example, they may need some blood biomarkers and not easy to use in a community setting. So for public health purpose, we may need simple tools and low cost, and for the screening and the monitoring. And finally, I think this factor need to surrogate for associated healthy promoting factors. So this study aimed to identify modifiable nutritional or diet-related risk factors for mortality in the older Taiwanese population, as well as develop and validate a composite, non-invasive, gender-specific healthy aging nutrition index for survival predictions. All participants of this study is from Elderly Nutrition and Healthy Survey in Taiwan, 1999 to 2000. All participants are Taiwanese nations ages 65 and over on the 1st January 1999. And this survey excludes those resisting in institutions, such in hospital, school, or training centers. And the sampling design of this study was stratified cluster multi-stage probability sampling design. Therefore means the results is a representative data set. And a total of 1,937 persons completed interview and recruiting needs analysis. Here is to show the flowchart of participants' selection and the procedure for the development of gender-specific HANI. We use the randomly allocation by region and random divided the participants into development set and validation set. For the development set, we use develop an algorithm for gender-specific HANI, and use this algorithm, apply this algorithm scoring system to the validation set for confirming the predicted accuracy or ability of this index. In this survey, the data was collected by face-to-face interview and the physical examination, and face-to-face interview to collect the baseline characteristic. For example, physical activity, personal behaviors such as smoking and drinking, and the shopping or cooking frequency, and the eating arrangement. That means who prepare food for you, or are you eating with someone? And dietary information were collected by 1 day 24-hour dietary record and a simplified food frequency questionnaire to collect the quantitative and qualitative of dietary information. And physical examination collect the anthropometric measurements and the bladder and the urine to determine the biomarkers analysis. And we use this information to develop a HANI score. And firstly, we check the HANI score associated with some indicators. We check the distribution of a healthy relative quality of life and activity of daily living, muscle mass, cardiometabolic factors by HANI. And furthermore, we conduct a cohort study. We link nested data to Death Registry 1999 to 2008 for confirming the survivorship of participants. And here is a procedure how we can select the variable and develop this score. The first step, we select 11 candidate factors on the basis of prior knowledge of this population and a literature review. Here is 11 indicators we include in the first step. including appetite, chewing ability, dietary diversity score, vegetable expenditure, cooking frequency, eating with others, and alcohol drinking, shopping frequency, physical activity, body mass index, and waist circumference. And following step, we evaluated the association between these candidate factors and all-cause mortality by using two step-by-step cost proportional hazard regression. Once the indicators of once the hazard age-adjusted hazard ratio of this indicator less than 1 was selected to the next step. So the indicator in the black dot. The third, the procedure. We put this index into the multivariable adjusted gender-specific model. Once the indicator P less than 0.05 and reveal 4 factors for men and 2 factors for women, the dark in yellow. So in men, we found the appetite, dietary diversity score, eating with others, and body mass index. They highly correlated with risk of all-cause mortality, even they put in together in the multivariable model. And in men, we found the cooking frequency and body mass index. Even the dietary diversity score, the p-value now less than 0.05. But from the literature review, we found that dietary diversity score is very important regarding to health and the mortality and the nutritional status. That's for we put a DDS for women. So here is the original question to collect this information. Actually, this question is very simple, so can answer by the participants themselves without interviewer. So firstly, for appetite status, the question is how is your current appetite? And the response was poor, fair, and good. And eating with others was asking, do you eat with others at least once meal a day? And the response is yes or no. And do you have a cook or prepare food for yourself or help with this? And this is do not include the ready-to-eat meals. For the DDS, they have something different with other international study. Because we use the Taiwanese food-based dietary guidelines, and we suggest our population to eat 6 food groups, including grain, dairy, and protein-rich food, meat, fish, egg, and legume or soy, and vegetable, fruit, and fats and oils. So the question from the NESA data is measured by a 24-hour dietary record of a 6 food group. But if in the community setting, we asking the participants the following question: did you eat more than half a serving size of any of the following food yesterday? And for body mass index, the cut point was based on the recommendation from the Bureau of Healthy Promotion in Taiwan. Less than 18.5 as underweight, and 18.5 to 23.9 is normal weight, and 20.0 to 26.9 is overweight, and greater or equal to 27 as obesity. So the final step is that we have scored in these factors. So we assign a score of each select factors by dividing each beta coefficient in the final model by the lowest beta coefficient and the rounding to the nearest integer. So our scoring, if those who appetite report they have a fair appetite, they got 7 points. And for those who report they have a good appetite, and they can gather 9 points. So a total 25 scored in men and 27 for women. So the following will display our results. Because this index was developed in the development set, so the following results was shown in the validation set because we want to confirm they have a predict accuracy of this index. So the first figure is for the cumulative death rate in the validation set. Both men and women, we divide the HANI score into 3 groups. For men, less than 40, 40 to 16, and greater 16. And for women, less than 14, 14 to 20, and greater 20. This cut point was by Yi-Chen index. So both men and women with a greater HANI score, greater 16 and greater 20, tend to have a lower cumulative death rate. In contrast, for those who had a lowest HANI score, they tend to have a higher cumulative death rate per 1,000 person years. The following is regarding percentage of living arrangement and social engagement in the validation set. Men with a greater HANI score, they tend to have a lower percentage of live alone and less social engagement. And for women, those who with a greater 20 score, they tend to have a less social engagement but higher living alone. So that's a little bit different both in gender. And the following is a healthy condition by HANI in the validation set. For the healthy condition, we check the cognitive impairment. This is evaluated by the short portable mental status questionnaire, SPM-SQ. And we check cognitive impairment and the activity, daily living, and the Charlson Mobility Index. And both men and women with the highest HANI tend to be less cognitive impairment and the less difficulty in activity of daily living, as well as Charlson Mobility Index. Here is a full intake in the validation set. Men with a greater 16 had a higher daily frequency of vegetable, fruit, dairy, and seafood intake. However, in women, only fruit intake was higher than the lowest HANI score group. For the nutrient intake, both men and women with the highest HANI tend to consume more vitamin C and calcium. And for women, they consume more, especially for women, they consume more dietary fiber and vitamin B2 and the magnesium intake than those did with HANI less than 40. And here is a healthy relative quality of life. And this is measured by the Chinese version of the short form 36, and total of 8 dimensions. Our finding found that both men and women with the highest HANI score had a higher score for each component of a short form 36. But in men, except for the mental health, others is a significant differences between these 3 groups. And for the indicators of muscle mass, participants with a higher HANI score had a greater muscle mass, including skeletal muscle mass and the mean arm circumference and the mean arm muscle circumference. And also they have a higher body fat that's measured by tricep skin fold thickness. And for the cardiometabolic factors, men with a HANI score greater 16 had a higher triglyceride and the lower high-density lipoprotein levels, and while women with the highest HANI score had a higher total cholesterol and LDL. Here is the figure is to show the area under curve of the time-independent receiver operating characteristic for HANI score. Upper is for in the development set, and the below is in the validation set. The predicted ability of HANI is a red line, and others is individual components. And from the result, we found that the predicted ability of HANI is superior to that of any individual components. So that means the integrated indexes have a higher predicted ability rather than individual. This is another static, we call C-static by logistic regression. This is to evaluate the predictor accuracy. In the development set, C-static was 0.78 and 0.76. And this is similar in the validation set and the full cohort, even a little bit reduced. And for the cumulative survival curve in the full cohort, we found men with a higher score, that's a green line, have a higher cumulative survival, and the similar phenomenon was found in women. And for the development set and validation set, especially in men in the validation set, we found that men with a HANI score in 14 to 16 and greater 16, actually they have a similar cumulative survival. So for the further analysis to evaluate the association between HANI and the risk of all-cause mortality, for the anti-cohort, the hazard ratios for men with a HANI of 14 to 16 and the greater 16. The hazard ratio was 0.05 and 0.35, means the HANI score could reduce the 50% and the 65% of risk of all-cause mortality. And men with a highest HANI exhibit 30% lower mortality risk. And for 2 points increases, reduce the 18 and 48% of risk of all-cause mortality after adjust for some confounding factors. And here is in for the validation set. The hazard ratios for men with a HANI of 14 to 16 and greater 16, the hazard ratio was 0.56. And for women, the hazard ratio in the greater 20, the hazard ratio was 39. And the 2 point increases still significant to reduce the risk of mortality. But however, the magnitude for this change was reduced after adjust for age in the validation set. And furthermore, we done another study to check how about this index can be worked in a community setting. So we done a small sample size around 64 participants recruited from the Taiwan community setting. And we use mini nutrition assessment to measure, to evaluate the malnutrition and compare these three indices, the area under the curve. One is a MMA short form and one is a determine, which is developing in the United States. And HANI is developing in Taiwan. So we found that MMA short form and the HANI score, they have a similar area under the curve to the malnutrition. The value is 0.933. So in this study, we found we developed a gender-specific index for survival prediction, will include the dietary pattern, food preparation, social circumstance of eating, and the body composition. Especially for the social constants, this is a similar concept with a Mediterranean diet. You have enjoy your food with others. And these integrated indices can be used in the community setting to encourage older adults to have a better appetite, eating with others, more cooking, more diverse diet, maintenance of a healthy body composition. However, in this index, they have some gender differences. Both found that DDS and body mass index is correlated with risk of all-cause mortality. Body mass index probably regarding to some kind of sarcopenia and frailty. But for the DDS, our study found that even this is a simple indices, the score range is 0 to 6 because when someone they achieve a half of serving of 6 group, and they can get 1 score. So 6 group, the highest score is 6, and higher score indicates better dietary quality. Even this index is very simple, but it can predict all-cause mortality compared to another complicated indexes. And for men, we reviewed another 2 factors, appetite and eating with others. And for women, we reviewed cooking. And cooking may be cooking frequency regarding to related to planning, you have thinking and the food choice, and you have some physical activity. And for appetite and eating with others, our previous study found that poor appetite is associated with lower food and nutrient intake and an independent risk for older adults, Taiwanese. The association was mediated by gender health and dietary diversity in its predicted capacity for mortality. But however, in the HANI score, we only found the recruit in the men, not for women. A possible mechanism is that testosterone level decline with age and are inversely associated with lifting level, thus leading to diminished food intake and an increased metabolic rate. Another study regarding to eat with others. In this paper, we found that gender differences in longevity in free-living older adults who eat with others, especially for men. The daily frequency of eating with others is highly correlated with dietary quality and the influence of their risk of mortality. So eating with others is an independent survival factor in older men and providing a social environment which encourages eating with others may benefit the survival of older people, especially for men. So in our study, we have some strengths because we use very simple, inexpensive, non-invasive tools to collect this information. So provide an accessible way to collect data without imposing burden on participants. They can answer by themselves and enhance participation and the feasibility for large-scale study. And our cohort is a representative, which help us to generalize the finding within the study population. And this survey includes a comprehensive dietary information, also including eating arrangement data. But we still have some limitation. For example, the muscle mass, cardiometabolic factors, and healthy relative quality of life were collected at the same time with a HANI index. So we cannot have a causal relationship determination. And even with adjust the many factors, but still some potential residual confounders unmeasured variable influence the results, which could affect the findings. And while the cohort is representative of a certain population, but the finding may not fully apply to different demographic or cultural groups. And these findings should support the public healthy policy to improve the nutritional status and the healthy relative quality of life in community dwelling older adults. That's for when we teach in the community setting, we will ask the participants to count their HANI score, let them know what factors related to their health. And this gender-specific HANI could enable such a policy initiative to be better integrated. So we demonstrate that composite nutritional modifiable factors categorized by engagement and ultimate consumption of a diversified diet conducive to higher survival. And HANI in this particular study context may be surrogate for association healthy promoting factors. We also create a website, or maybe if you are interested, you can screen this QR code to access to this webpage. This webpage provides both Chinese and English version, and they can count the HANI score. So I know you are not greater 65, but maybe you can try this score. And in this web page, we can just count the mortality rate or the survival rate, and to provide this information to our participants. And So we show the 1 year, 3 year, and the 5 year mortality rate. So this is an example we can use in the community setting. So from this web page, they can know they have to eat the 6 food group per day, and they encourage they can more cooking frequency, something like that. And finally, this paper is published a few years ago, and this is supervised by Professor Mei-Shen Li and Professor Mark Walquist. And here is all my presentation. Thank you for your listening.
Thanks for Professor Huang for your nice presentation about your study about the HANI score in Taiwan to predict the outcome in the old people, especially about the mortality and others. So I know all 3 speakers, all of them control the speech time well. So we still have some time to have the panel discussion about 20 minutes. Okay.
Yeah, we have a very long hour for you. So if anyone have any question, comments, or critiques, please raise your hand and give our speakers some hard time.
I have a question for Professor Ozuka. Thank you for your excellent talk, and I'm very interested in your community intervention, community model for promote the elderly healthy diet. But I'm very curiously, you seek for the help from the pharmaceutical company, because for the pharmaceutical company, they are not very familiar with the cooking or nutrition research. Yeah. So I don't know what is the logistic. Is the company just provide a funding source, or they collaborate with the researcher in your center to work together to develop some nutrition menu? And the other thing is that for those who came to the community center, do the older people have to pay any money to eat in the center? Because in Taiwan, we have a they just only have to pay very little money. And they can eat together in the community center.
Okay, thank you very much. So in that case, so we collaborate one of the famous company Eisai. So Eisai has no charge to God. The community dwellers have no pay to the pharmaceutical company. The Eisai is a drug company, so they deliver the Alzheimer's drugs, and they contribute to the social. So just as volunteer as that case. So we advise the evidence or scientific evidence to the Eisai's company, and so there are no charge. So a community dwellers not to pay any money to the company. Okay.
I think the question is who pay for it?
Who
pay for it?
Who pay?
With no free lunch, right? We say there's no free lunch, but who pay for it?
Business is only the food company. Food company delivered with health information to the community dwellers. Community dwellers to pay the food company, but the charge is a meal delivery charge. So do you understand?
So basically, the customers need to pay for the lunch, the meal box. And the Eisai spend the money for supervising the menu of the diet. And the purpose is Eisai is selling Alzheimer's drugs and also lecanemab, new disease-modifying drug. So that's one of the social contribution of the company. And is it clear? Okay. And about the lunch in the community center?
Lunch community center, no charge.
No, I think no charge like Taiwan.
Just a community center. Okay.
So even though small money was still later, maybe privately we can make it more clear. And there's another question over there, that gentleman there.
So I have a question for Professor Osuka.
Yeah.
You mentioned about the food diversity correlated with the cognitive impairment. But from your data, do you have any information to suggest that is it the middle life food diversity or later life food diversity that associated with cognitive impairment? Can you tell from your data the middle life and the later life food diversity?
I showed the data, but midlife and old age dietary diversity is positive to keep their cognition. So both.
Because people who got some cognitive impairment tend to have a monotonous food, you see, because of the cognitive impairment. But your data can show that it is the cause, not the result.
In our study, so the subjects are consisted of middle to older adults. So I usually combine them. So
Did you divide the cohort into middle-aged and older people?
Not yet divided. Sorry.
Combined data. And interestingly, this result is positive in only women, not men. Because men just wait. In Japanese, men just wait for the dinner meals. They don't have to cook. So, but women need to cook several food, and that's a kind of a cognitive dual task. So sometimes they need to prepare 3 or 4 dishes, and they need to prepare 3 or 4 kind of dishes at the same time. So that's kind of a dual task approach during cooking. So that may be effective for cognitive, prevention for cognitive decline.
Thank you. Questions for Dr. Huang, and regarding your, I believe on your slide number 32. It's okay. I think you mentioned about the gender difference among the male and the female. And you mentioned for the female, they have the cooking frequency, okay? But on your abstract on the book, okay, it says that both the HANI, the score is good for them to lower down the mortality, okay, especially for women. And you say that also along with better quality of life and more muscle mass. This apply to both genders?
Yes.
Okay. Did the difference between 2 genders, did the women's reach a significant difference in the muscle mass since their cooking frequency is higher?
Oh, so you mean the cooking frequency of influence their muscle mass?
I don't know. I just wonder.
Actually, we found both men and women, those who have a higher index related to good muscle mass. Yeah, but we did not check the further like other ratio. We just see the distribution.
Okay, yeah. And just want to understand that since the cooking frequency, I just wonder, did you also investigate the cooking method, stand or boil or pan fry or deep fry, because this eventually affect the mobility of lung cancer for air pollution. I just wonder, did you check the cooking method?
Maybe this can be another topic for our next research, because in this study we only check the frequency of cooking.
I see. Yeah. Okay, I understand. Thank you.
Thank you.
Hello. Hello, this is Kenny from the Hong Kong Polytechnic University. I have a question for Dr. Zhuang. Yep. So, for your analysis, you hypothesized that so maybe for people with poor oral health, they may substitute their diet with easier to chew food so that they may have a more inflammatory diet. I wonder, so your conclusion, does it come from some related literature, or you have done some analysis in your data set showing that maybe for those people with poor oral health, so actually they do consume more refined grains or other easy to chew foods, And I also wonder, so what do you think about like maybe doing some substitution analysis in your data set so as to simulate when people are having, like, let's say, more whole grain and to replace less whole grain and to replace it with refined grain. So does that also affect frailty? Because I feel like if we can take a deeper look into the individual dietary components, then we can see more specific details on like how people change the diet because of their oral health.
Yeah, this part of analysis is currently ongoing because we have so many food items and food groups, and so we still trying. We have some preliminary results, but we are still trying to kind of figure out how to rank this association because there are so many variables. So there is always kind of risk for the multi-comparison issues. So we don't. So in the analysis, everything comes out to be associated, and we are still thinking in those associations which one are real. So in another way, we are still trying to interpret those associations because there are so many associations. Yeah.
Thank you very much.
I have a question for Dr. Huang. You show a validity test comparing the MMA and the HANI score, right? And actually, the validity test, the ROC under curve, very similar. So I have a question for you that because most of the people are familiar with the MMA. So if these two scores are very similar, why bother to use a new score? This is one first question. And the other one is that do you compare your score, your HANI score, with the DDS score? Because it seems to me that DDS score is very important in your composite HANI score. And I didn't see the comparison between these two.
For the first question, actually, this is very important. This study is done in 2008. Actually, it's a few years ago. And why in 2008, I searched in the kind of paper. Actually, there's a few regarding to mini nutrition assessment short form in relation to all-cause mortality, because that's a sixth question. And that's inspire me. Maybe we can have some score that's predict mortality, not for male nutrition. But why we compare in the community setting for the malnutrition, I wanted to know whether this index can be also predict malnutrition as well, not only for the survivorship. And I think in the HANI score, the question tend to be you can answer just by yourself. But in the mini nutrition assessment in the community or hospital setting, I think that's evaluated by the male caregivers or nursing, not by themselves. So I think there's a little bit difference in these two assessments. Another question is for the DDS. Yes, actually, dietary diversity score is very important to our diet. And we found that compared to another complicated index, they have a higher predictive, even that's very simple. But overall, we put HANI and compare with just the individual DDS to predict mortality. For integrated indexes HANI, they have a higher predictor ability rather than the individual DDS. And another issue is to put DDS into this score. I think diet is very important regarding to nutrition and our longevity. In this index, I think the most importance is to remind our older adults diet is very important, and that you just eat 1/2 of serving per day for each food group, and you can get a more dietary diversity and have a better diet quality. So I think that's the reason why we put the DDS into this score. Yeah, thank you.
I can add one comment about the cooking issue. I think the gentleman sitting here maybe feel frustrated, or female feel frustrated. You have to cook more to live longer. Well, but maybe there's a social context, because this study, when we have the data, is 1999, when they were older. But for the newer generation, people like you, maybe you learn how to cook, can benefit for your health too. So I think that it's not gender discrimination, but do have the gender different, the social context over there. And this is a good question raised by Dr. Xu about why the HANI seems not very well adopted by other community. I think that something is exchanging. For instance, that cooking, this issue, very significant for women. But when the time being, maybe nobody want to cook. Just call Uber and send to you. That's bad. That's bad. I think that we should. And similar as that Japanese study you show, cooking also important. So encourage men to cook too, right? Is any more?
Similar question. So I have a question to Dr. Huang. So I found the testosterone in your HANI score only in men. Do you measure testosterone in the plasma or any kind of measurement for testosterone?
No, that's one I found in another study.
Oh,
yeah.
You didn't measure testosterone in your study?
Not in my study. Yeah.
Okay, and again, you didn't include the cooking in men, right? But in Japan, we have only almost 6 million older people living alone, and less than half are, older men living alone. So they need to cook by themselves. So it would be better to have some score for men to address the question by the chairman.
Actually, because the cooking frequency is not selected by the statistic model, it's not choice by ourselves. So maybe in Taiwan, cooking is not important for men.
In this cohort, we actually analyzed many data, and individual paper has been published. I can tell you one thing is good for men than women. It's shopping. Okay, not window shopping, not surfing from your mobile phone. Is go out to have a more social engagement, to do some calculation, brand new. Okay.
Another small question for Professor Huang. In the HANI score about only the cooking behavior, I wonder about the meal time. Some people, they have 2 meals a day, and some people have 3 meals a day. And the regular meal time or irregular meal time also important to predict the outcome.
Yes, actually, this is important questions. The skip meals or frequency of meals, I think that's highly correlated with nutritional or energy intake of older adults. But in our study, we did not include this index into our HANI score candidate factors. Yeah, but maybe we can think about how about the frequency of meals in the future.
For the Professor Osuka, about the food pharmaceutical, about the food composition, the consistency, different consistency from the pharmaceutical, because some older people have a different oral condition. So the food, they can choose different food, some the soft food or some the more fruit, yes.
Yeah, so I showed the food companies' delivery system today. So there are several kinds of food companies. Some company delivers the soft food, or some company delivers the disease-specific food. So for example, so after stomach surgery patients for delivery meal, so the older adults easily choose any food company. So food company have several choice. So, it's okay? Okay.
Question. So we save some time for us. So maybe we can have a longer tea break. How about that? That if you have any question, then we can go just stay here and to discuss with our 3 speakers, or you can have your tea break. Okay. Thank you for everyone.
Thank you. And thanks for the speakers and participants for bringing us a vibrant discussion and stemming from the facts and inspire us in healthcare practice in the household. So we would like to express our gratitude to our speakers. So let's invite our moderators, represent the organizing committee and National Health Research Institute to express our gratitude by presenting the certificate and the small gift. Please come to the front of the stage. Thank you, Professor Zuka. Thank you, Professor Zhuang. Thank you, Professor Huang.